All right, everyone. Let's start today's discussion on lymphoma, and I have purposely kept the topic as what is lymphoma because we are going to look at an overview of lymphoma. It is such a vast topic that there is no way we can cover basics or current management or whatever of lymphoma in anything less than 2 to 3 weeks. So that is why the topic is what is lymphoma, because we are only going to give you an overview. The goal, as always, is for you to understand the basics, for you to understand when to suspect this disease, what is the usual evaluation, a broad overview of what are the types, treatments, and outcomes. All right. So, lymphoma is essentially a kind of blood cancer. Like I keep on saying, the abbreviation I use is LLM: leukemia, lymphoma, myeloma. Easy way to remember the names of the three blood cancers. Now, this is a blood cancer of lymphocytes. Very simple. Like AML is of myeloid series cancer, and ALL is lymphoid. Similarly, lymphoma is also lymphoid, and myeloma is of plasma cells. Okay, so this is a blood cancer of lymphocytes, which are part of our immune system. And more importantly, the cancer cells are mainly located in the lymph nodes. We are all aware that a very important part of the circulatory system is the lymphatic system. This is the system where there are pipes called as lymphatic vessels, and on the journey that these pipes make at strategic areas, there are junctions which are called as lymph nodes. Lymph nodes are junctions in the lymphatic system, and essentially what they do is the nodes are a storehouse of lymphocytes. Okay, it's like a storage area. Plus, the lymphatic fluid is filtered through the lymph nodes, and as it is filtered, the bacteria, viruses, even cancers which pass through, anything that is antigenic can be sensed, and thus an immune reaction can be created to protect the body. So in this cartoon of one individual, you can see there are lymphatics, which are pipes. They carry the lymphatic fluid, and there are nodes starting from every kind of a bony joint. So from the popliteal fossa to the inguinal, abdominal, above the diaphragm, mediastinal, and from the upper limb going up across the course of the upper limb, but mainly concentrated in the axilla, and from the head coming down towards the cervical area, and then all of these drain into the heart. That's how the lymphatic is circulated. So why should we study lymphoma? How common is it? About half of all blood cancers are lymphomas. So LLM, leukemia, lymphoma, myeloma, 40 new patients per lakh per 100,000 population per year. Half of these, so about 20-22 patients per 100,000 population per year, are actually lymphoma, different kinds of lymphoma. So in our country, per year, we have about 3 lakh, 300,000 new patients, and per day, we have 800 new patients. But that's not the most important thing. In my mind, we need to know about lymphoma because we often miss the diagnosis. We are so involved and consumed and obsessed with tuberculosis that anybody and everybody who has a lymph node enlargement, we start thinking, all right, cox. And almost every lymphoma patient that we get was previously misdiagnosed as cox and has even received anti-tuberculous therapy, and sometimes gotten hepatic derangement due to anti-tuberculous therapy before the lymphoma is actually diagnosed. Now, this does not reflect very well on us doctors. Unfortunately, in our medical training, we were taught that in our country, anything and everything can be COX. The TB can cause everything except pregnancy. We have been given these aphorisms, these statements while we were growing. So we tend to overdiagnose and overtreat tuberculosis and miss lymphoma, sarcoidosis, histoplasmosis, etc. However, now we should not be doing that. And how do we prevent this from happening? Let us understand a little bit. Let us also understand how do we ensure that we don't miss these critical diagnoses. So that's a lymph node. You can see there are afferent lymphatics. That means these are the areas where the lymphatic fluid flows inside. The lymph flows inside. It is kind of strained, filtered, and there are lymphocytes in the structure of the lymph node. They will sense the antigens and create an immune response if required, and then the lymph flows out of the efferent lymphatic. Where does this lymphoma occur? This is a cancer, like I told you, it is mainly restricted to the lymph node. Well, it mainly, the cancer cells are mainly in the lymph node. But we have to understand that the uh, hematologic system, the lymphatic system, is quite wide in the body. It is not just the lymph nodes. We also have liver and spleen, which are equally important part of the lymphatic system. They are also filters. They are also part of immune sensing. Then we have the bone marrow, which is a factory that makes lymphocytes, and these come out in the blood. We have other lymphatic organs such as tonsils, right? And if you actually think, tonsils, intestines, all of these lymph nodes, they are placed at points in our body anatomically where infections can enter the body, where antigen exposure can happen. So we have tonsils to sense everything that we eat and drink, right? We have intestines which have lymphoid follicles. There can rarely be lymphoma in the brain. And then we have a major lymphoid organ called thymus until adolescence. So lymphoma can occur in all of these different sites. Mainly the cells are sitting in the lymph node. How does this happen and how does this spread? All of us have normal lymphocytes, of course, except those who are born with immunodeficiency syndromes. But all of us, or most of us, have normal lymphocytes. And as the lymphocytes mature and more lymphocytes are formed, sometimes there may be lymphocytes which acquire mutations, which are genomic errors. These genomic errors can convert a normal lymphocyte, one normal lymphocyte, into a cancerous lymphocyte. And that one will multiply into 2, 4, 16, 80, 100, 1000, lakhs, etc. And these cancerous lymphocytes are then called lymphoma. They are initially localized, usually, like I said, in the lymph node, sometimes in the stomach, intestine. We have gastric lymphoma. We have, intestinal lymphoma. Sometimes we have lymphoma cells in the bone marrow, in the blood as well. But eventually, as the disease progresses, in most of the patients, the lymphocytes, the bad lymphocytes, will spill over into the blood and the marrow and lead to what is called as leukemic phase of lymphoma. So starts with one place, then goes to other neighboring lymph nodes, and may also go to adjoining tissue, right? And eventually spill over into blood and bone marrow. So that is how it spreads, and that is called as the stage of lymphoma. So for example, if I have a patient who just has, this is a PET CT image. These are PET CT images. So if I have a patient who only has axillary lymphadenopathy, right? Left axillary, only in that place. And we have done PET CT and it is not showing any lymph nodes anywhere else. One area, that is stage 1. As it multiplies, if it goes to 2 areas, but on the same side of the diaphragm, okay? So they are either in the thorax or in the abdomen, or they are below in the inguinal, whatever. But 2 different sites of lymph nodes. But on the same side of diaphragm, it is stage 2. When the lymphoma spreads so that multiple sites on both sides of the diaphragm, so it has crossed the diaphragm, we call it stage 3. And stage 4 is when it is practically everywhere, and even if it is in the liver, lung, or bone marrow, we call it stage 4. You can imagine, if we delay the diagnosis, you know, if we think, no, 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 this is lymphoma, I mean, this is tuberculosis or bacterial infection, I'm going to give antibiotics, and oh, I'll just wait, or I'll give empirical ATT, and the longer we wait, the more it is going to spread, and the more difficult it becomes to treat, and the less is the chance of cure. Okay, but nevertheless, this is how lymphoma happens, occurs, and this is how it spreads. Now, what are the types? And when we look at hematology cancers, the most important classification which we all follow is the WHO classification. The fifth version was released just last year, actually. And what we need to understand, that if we are going to look at the different kinds of lymphomas, and there are about 30-40 different types of lymphomas. Okay, but before we go to that, let me first give you some plain orientation, simple orientation. So if you look at cancers of lymphocytes, when a lymphocyte becomes cancerous, if it becomes cancerous to the extent that it is the cells are dividing very rapidly, and they are immature cells, and they are dividing and spreading rapidly, and the patient will present to you in an acute manner. Acute meaning just 2-3 months history: fever, cough, infections, bleeding, whatever, very rapidly dividing immature cells. Then actually that is not lymphoma, it is leukemia, and we call it ALL. However, what happens in lymphoma is it grows slowly. They are slightly more mature. They are not immature cells like blasts. They are mature cells, and because they are growing slowly, and because they are spreading slowly, they are largely restricted to the lymph node, unless of course you ignore and then they spread everywhere else. But it takes months to years for the patient to come to you. They are not very symptomatic for a very, very long time. Going beyond that, okay, now we know this is a lymphoma. It grows over months and years, and not aggressive, as aggressive as an acute leukemia. How do we divide? We divide lymphoma into Hodgkin lymphoma and non-Hodgkin lymphoma. Very simple. The initial classification is either it's Hodgkin or it's NHL, non-Hodgkin lymphoma. How do we know? When we do a biopsy and our pathology colleagues look under the microscope, they will see what is called as RS cells, Reed-Sternberg cells. Okay, this is a Reed-Sternberg cell. You can see there is one cell which has two nuclei. They're adjacent to each other. This is called as owl eye. It looks like the eyes of an owl. So owl eye nucleus, Reed-Sternberg cell, Hodgkin lymphoma, good chance of cure. Okay. If they don't see Reed-Sternberg cell, then it's called as non-Hodgkin lymphoma. Okay. And all other 30-35 types come under non-Hodgkin. How? What are these 30-35? They can be created from a cancerous B lymphocyte or T lymphocyte. Okay. There are two kinds of lymphocytes, B and T. Of course, you also have NKT. But commonest NHL, non-Hodgkin lymphoma, is a B cell lymphoma. Even this has a good chance of cure, right? And these are the commonest types. So the commonest is called diffuse large B cell lymphoma. So if somebody asks you what are the common types of lymphoma, Hodgkin, DLBCL. These two are the commonest types, right? Then of course there are others, follicular, then CLL. So you see CLL is chronic lymphocytic leukemia, CLL. If the cancerous lymphocytes are in the blood, we call it CLL. If the cancerous lymphocytes are restricted to lymph nodes, we call it SLL, small lymphocytic lymphoma, SLL. If restricted to lymph node, we call it SLL. If they're floating around in the blood, we call it CLL. It's the same disease. Okay. B cell type NHL. Then you have marginal, mantle, and Burkitt, and slowly the incidence goes down, the percentage of patients. So the commonest being DLBCL, follicular CLL in NHL. Then, of course, in some patients, the T lymphocytes can become cancerous. And these are slightly more difficult to treat. So the chances of cure are slightly less in TNHL. What are the varieties? Well, there is something called as PTCL. PTCL, peripheral T cell lymphoma. This is the commonest variety. Okay. Sometimes these T lymphocytes can be infiltrating the skin and lead to cutaneous lymphomas, what we call mycosis fungoids. Then you have ALCL and NK T cell lymphoma. Of course, there are many more, and I'm not getting into all the subtypes. It's only going to confuse you. Suffice to understand that cancers of lymphocytes, if they are acute, mainly in the blood, it's acute lymphoblastic leukemia, ALL. But if they are slightly chronic, subacute to chronic, localized mainly to lymph nodes and other lymphatic tissues, and if the cells are not immature, slowly growing, then it's called lymphoma. Lymphoma, Hodgkin, non-Hodgkin. If there is Reed-Sternberg cell, we call it Hodgkin. If that is not there, everything is non-Hodgkin. Within non-Hodgkin, there is B cell and T cell. And these are the common varieties and these are the basic characteristics. But how do we diagnose? How do we know what is actually happening to a patient? This is the core part of this talk for you. If you have any patient with any lymphatic tissue that is enlarged, so the lymph nodes are enlarged or splenomegaly, or your pathologist friends say, hey, there are some abnormal atypical cells in the blood, they're not really blasts, I'm not sure what's happening. Maybe there's a skin lesion which is not healing or it is recurring, and you have to think, okay, I don't know what is happening, and maybe let me figure out what's happening, let me do a more deeper diagnostic evaluation. How do you do a diagnostic evaluation? You will initially think, well, maybe this is just infection. If it is in the throat, lymph node enlargement is in the cervical area, you will look for dental infection. If it is on the occipital side, you will think of scalp infection, scalp eczema, right? If there is an injury on the leg, there may be infection with infectious enlargement of inguinal lymph nodes, lymphadenitis. So you will rule out these common infectious problems in the draining area. And sometimes you may not even find it. In fact, in majority of patients, you say, no, 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 we'll give a trial of antibiotics. So you may use a beta lactam, cephalosporin or amoxicillin. You give a trial of antibiotics. Sure, maybe for up to a week or so. But if there are more than one lymph node sites, so there is cervical and there is inguinal, they are in different parts of the body. That does not mean that there can be multiple infections, right? Or you have given antibiotics and you have given time, but it's been more than 1 to 2 months and the lymph nodes are not reducing, or they're even growing in spite of antibiotics. Or there are other general symptoms, so fever, night sweats, weight loss. We call these B symptoms going on for a few months, or the liver and spleen is also increased, or the LDH is high. If you have any one of these, then you have to have a high suspicion for lymphoma. Okay. You may wait and watch, you want to comfort the family. You say, no, 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 we'll give a course of antibiotic. But more than a month to 2 months, if the lymph nodes are not going down, please do not delay. Please do not give empiric anti-tuberculous therapy, etc. Okay. And that whole concept of the feel of the lymph node, it is rubbery, contiguous, non-contiguous, that's old science. We don't do that anymore. In fact, pathology has, even after a biopsy, pathology has progressed to a level where we are discovering new differential diagnoses and varieties of lymphoma and chronic infections, histoplasma, blah, blah, blah. So do not depend on contiguous lymph nodes, rubbery, this, that. No, more than one lymph node site, not responding to antibiotics, going on for more than a month or so, please biopsy. You cannot clinically diagnose a lymphoma. It is not possible. Don't take a risk. Why biopsy? Why not FNAC? I'll just put a needle and take out some cells. Not recommended. Not recommended. You know why not recommended? Because lymph node biopsy, when we get the whole node or even a part of it, if we do core biopsy, so if you can either do an open biopsy or just with a wide bore needle do a core biopsy, right? But we need a biopsy, not cytology. Why? Because in cytology you will get some fluid with some floating cells, and then you put that on a slide and you smear it, and you get very few cells, right? And in only 12% of patients will an FNAC give you the correct answer. Almost 88 to 90% of patients, your FNAC will not give you the answer. 90%. Why will you do that and waste time? We have to see what kind of cells are there, how are they arranged, are they arranged in a follicular manner, they're large cells, small cells. Only then can we diagnose a lymphoma. You can't even diagnose tuberculosis on FNAC. So we have to stop doing FNACs. Stop it. We waste time. That the family gets frustrated. We end up giving wrong treatment because we have not done the biopsy. So when there is a lymph node, if it's a superficial node, you best to do an open biopsy. Take enough tissue for different stains, different histochemical stains. If it's a deep node, you're not able to do a complete lymph node excision, then you can do what is called as a core biopsy, where you have this core biopsy guns, or you have a wide bore needle and you take a core, you take out a piece, a cylinder of the lymph node and send it to your pathologist. Remember, they need a lot of tissue for immunohistochemistry, right? So no FNACs. 90% of the time it fails, and you waste time and money, and your patient loses confidence in you. Patient will say, no, no, you have done one FNAC, and now why not do the right test? Okay. So with the biopsy, what we also do is we send the tissue for TB culture. That is the way to diagnose tuberculosis. Okay. So if you really think it is tuberculosis, or you're not sure, you take a biopsy, send it for pathology, immunohistochemistry, and you send some piece for TB culture. Right? That's how you do it. You can send it for TB PCR. And if the PCR is negative, culture is negative, you're sure there is no tuberculosis. You have a diagnosis. You don't waste time. Correct? You are not going to get granulomas. Most of the patients with tuberculosis will not have this perfect caseating granuloma and all that. So you have to take a proper biopsy. Don't do FNAC. Yeah. What is also important is that the histopathology is reported by trained hematopathologist. You see, pathology is a vast field and it's a very difficult science. It's not easy. Can an MD medicine or MD family physician, DNB family physician manage AMI without cardiologist? Can you treat blood cancer? No. Similarly, a general pathologist cannot properly report lymph nodes. We have hematopathologists now who has spent their life in looking at lymph nodes. It's not easy. I can't report lymph node pathology. Okay. It's very difficult. That's important because the eyes will only see what the brain knows. The eyes will only see what the brain knows. So what we do is we take a proper lymph node biopsy. It may turn out to be normal, right? Or it may show some abnormal cells. These abnormal cells, if they are Reed-Sternberg type, we call it Hodgkin, or they may be abnormal lymphocytes, large lymphocytes, diffuse large B-cell lymphoma. They may be small lymphocytes, SLL, small lymphocytic lymphoma. Now, this is just the HNE, the initial stain. Then, depending on whether the abnormal cells look Reed-Sternberg like, or large, or small, our pathology friends will do a whole panel of IHC. Okay. They will also see which area of the lymph node. Is it follicular? Is it the mantle zone of the lymph node which is affected? And thus make a diagnosis of follicular lymphoma, mantle cell lymphoma, etc. They will, with the immunohistochemistry, if CD20 is positive, they will say B cell lymphoma. But if CD20 is negative, if T lymphocyte markers are positive, then they will say T cell lymphoma. And they will do additional markers, right, to see what kind of T cell lymphoma this is. Then they will also see whether this is high grade or low grade lymphoma. Okay, high grade or low grade lymphoma. High grade means rapidly dividing, still not as fast as a leukemia, but relatively faster. They do that by doing what is called as a Ki67 stain. This is also kind of immunohistochemistry or MIB1 index. With this, they will decide whether this is a high grade diffuse large B cell lymphoma or low grade follicular lymphoma, etc. etc. So, all of this has to be done. Sometimes they will just see a granuloma and they'll tell you, hey man, this looks like tuberculosis or histoplasma, whatever, right? There are so many things that can happen. Everything is not TB, everything is not lymphoma. Sometimes they will use special stains. The special stains will tell us this is histoplasma or AFB staining for TB, correct? So, this is how we actually diagnose the lymphoma. I just told you using the MIB1, right? Or Ki67 stain, they will tell us whether it is a high grade or low. Once they say it is lymphoma, B cell, T cell, high grade or low grade, they look at the percentage of cells which are dividing. So if you count 100 cells, how many cells are mitotic? How many cells you can see? Hey, I can see a chromosomal mitotic bundle. So this cell is going to divide now. It is in the dividing stage, right? Cell division. And based on the percentage of cells that are dividing, okay, so this is a low grade lymphoma. So typically follicular lymphoma or SLL, small lymphocytic leukemia, that CLL SLL is low grade. Diffuse large B cell lymphoma is aggressive. Now when we do when we do Ki67 and MIB1, see the brown, the more the brown means more number of cells are dividing percentage wise. So this DLBCL is a aggressive high grade lymphoma always. However, in low grade lymphoma, you can see there is less brown. Brown is that special stain, immunohistochemistry stain. Okay. So they will tell us it is T cell or B cell, high grade or low grade, right? And depending on the grade, you see less than 30% of cells are dividing. Here, a lot of cells are dividing. In fact, in Burkitt lymphoma, the MIB1 index is 100%. Okay. Now, these are high grade lymphomas. They grow rapidly. They need urgent treatment, intensive chemo, and most of them get cured. However, low grade lymphoma, they're slowly dividing. Sometimes they will grow over years and patients don't even need treatment. Okay, we can wait and watch. If they are not causing any harm, if they are of a smaller size, we wait and watch. And these are low grade, we will not use very intensive chemotherapy. Sometimes we only use oral targeted therapy, right? However, we need to understand that chemotherapy attacks dividing cells. Okay, chemotherapy is a cell toxin. So when we give chemo, the dividing cell will eat it up and it's a poison and it dies. But in low grade lymphoma, follicular, CLL, hairy cell leukemia, remember, hairy cell leukemia is actually a lymphoma. Okay, well, that's the name, but it's actually a low grade lymphoma. In all of these, they're growing very slowly. So even if you give chemo, most of the cells are not going to eat it up. Most of the cells are not going to die. So getting cure is very rare in low grade lymphoma. Yes, you can control, but in 3 4 years it will relapse. If it relapses, you give the next line of treatment. Generally, low grade lymphomas cannot be cured. They can be controlled, but they are not aggressive. So usually they do not kill the patient. They do not increase the mortality too much. High grade lymphoma rapidly growing intensive chemo and can be cured. So this is the meaning of grade of lymphoma. Plus, what our pathology friends will do is we have some targeted drugs. So we have a medicine called rituximab, which works against a protein called CD20. So diffuse large B cell lymphoma, B cell, large cells, diffusely present in the lymph node, aggressive having CD20. So if I use rituximab in combination with chemo, it will selectively target the CD20 positive cell and kill it. So my efficacy of treatment improves, cure rates improve, relapse rates come down. So lot of IHC done by pathology friends are to help us decide the treatment. Hey, it is CD20 positive, give it. Or it is CD30 positive. There is another targeted therapy called brentuximab, right? So IHC is also done for targeted therapy. Now, obviously, you can't do all of this in your FNAC. So you understand how much little information we get. Once we have a diagnosis, often what we do is we also do some genomics. For example, DLBCL, diffuse large B cell lymphoma, excellent chance of cure. But if the c-MYC is positive on immunohistochemistry, c-MYC, not good chance of cure. So this is called as a double hit or double expressor. So when DLBCL is CD20 positive, in addition BCL2, c-MYC positive, the chances of cure go down. And you know that, hey, you can't just do chemo, you may also have to do a transplant. So this helps us in prognostication, right? To intensify treatment by giving higher chemo, by planning stem cell transplant to try and cure the patients. So this is why we should do a biopsy for diagnosis, the type of cell, the pattern of the lymph node involvement, the aggressiveness, targeted therapy, prognostication, etc. All of this information comes only from biopsy and immunohistochemistry, nothing else. Now that you have this information, how do you treat? Well, you've done proper immunohistochemistry, good hematopathologist has reported, you trust the diagnosis, then you see how much has it spread, how much has it spread, staging. So you understand, grading means aggressiveness, staging means how much has it spread, stage 1, 2, 3, 4. Okay, sometimes we also do genomics for prognostication, and then we, depending on the lymphoma, we either use chemo protocol or chemo immunotherapy. So I told you CD20 positive DLBCL, we use rituximab, which is an immunotherapy medicine. Whereas Hodgkin, we only use chemo, ABVD, four medicines, ABVD chemo. So depending on the type of lymphoma, we give choose a protocol, either chemotherapy or chemoimmunotherapy. We give it for about 2 to 4 cycles, and then we repeat the PET CT. This is called as an interim PET CT. Interim. This PET CT will tell us initially the node was this big, now it has shrunk to this much, or it has not shrunk, or there are new lymph nodes in spite of chemo therapy. Okay, so we, after 2 3 cycles, we repeat a PET CT. Now if that gives us, okay, good response, that means less than half of the lymph node is remaining, less than 50% remaining, means more than 50% is dead. Good response. Continue the same cycle. You don't have to change treatment. Complete 6 cycles of chemo, repeat one more PET CT, ensure that there is complete response. Complete response means the tumor is completely gone, the PET CT is not showing any uptake. Wait and watch, do clinical examination, tell the patient, hey, great, you've completed 6 cycles, great response, there is no evidence of lymphoma. Doesn't mean that you're fully cured, okay? You have to keep on coming every 3 months. I have to see if the lymph nodes grow back. Yeah, we can do PET CT, but not more than once in 6 months. 6 to 12 monthly, you do a PET CT. Okay. However, if your end of treatment disease shows, no, 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 there is still some lymph nodes are remaining, 100% of it is not gone. So, should we give more chemotherapy? Possible. Sometimes we give maintenance rituximab, or if it's at one area, we just give radiation and kill off that lymph node. Okay. So, you don't have overall side effects of chemoimmunotherapy. What about somebody who does not have a good response? That means interim PET CT shows more than 50% of lymph node is still there. Yeah, not very good response, right? Now you have to intensify treatment. You can't continue the same one. So you have to change to a higher dose, newer drugs, newer immunotherapy, and you have to save the patient. So this is called as salvage chemoimmunotherapy. Salvage means save the patient. Your frontline treatment has not given good response. So you have to now save, you have to salvage the patient. So you use higher doses, different chemoimmunotherapy protocol, and then you have to do an autologous transplant because this patient has had a poor response to chemo. Unlikely that he or she is going to get cured with just chemo. So later on, you have to do a transplant, autologous, allogenic, depending on the type of lymphoma, etc. So just to tell you, we do initial PET CT, we do interim PET CT, and we do end of treatment PET CT. And then later on, we follow up with PET CT once in 6 to 12 months. Okay. If your later PET CTs don't show any uptake, any enlarged lymph nodes, etc., spleen has normalized, everything is fine, we call it CR, complete response. And if there is no PET uptake, FDG uptake, we call it metabolic CR. That means even not just CT scan, but PET CT, metabolic CR. Okay, there is no increased uptake. If less than 50% is remaining, we say partial response. More than 50% is remaining, then we say less than partial response, or we call it refractory disease. And if the lymph nodes are actually growing in size in spite of treatment, or initial PET CT showed in one place, now further PET CT showing new sites. So that's when we call it progressive disease. So these are the broadly four categories of assessment of treatment by PET CT. These are the usual chemo regimens for ABVD. We use only chemo, or there are newer immunotherapy medicines. B cell lymphoma, like DLBCL marginal, we use rituximab plus chemo regimen. That's why it's called chemoimmunotherapy. There are newer medicines, polatuzumab, with excellent chances of cure. T cell lymphoma, immunotherapy is a bit less, but we still have something called brentuximab against CD30. If But this is expensive, newer immunotherapy, so if they can't afford, we use CHOEP, so that is CHOP plus etoposide, we call it CHOP. And when there is relapse or refractory disease, we use salvage chemo, which is higher dose. There are multiple regimens, RGDP, RRICE, etc. Okay. After all of this, what are the chances of cure? In Hodgkin, it's excellent. Stage 1, early disease, 90% get cured. They will not even relapse. Most of them, one shot treatment, they'll get cured. Even if it is advanced, 70% will get cured. So 70 to 90% of Hodgkin patients are going to get cured. Okay, great disease. So don't delay diagnosis, don't let it progress. DLBCL, about 60 to 80% will get cured depending on the age, stage, etc. CLL, very common in elderly group. CLL, SLS, chronic lymphocytic leukemia. We don't think of cure, we try to control. Long-term control, low-grade lymphoma, control. Remember, there are oral medicines which are available now. Many patients don't even need chemo. Similarly, T-cell lymphoma, chances of cure are there, but much, much less. As of now, difficult to cure. Okay, so most of T cell lymphoma patients, after chemo, we have to do a transplant. Most, not all. However, the worst lymphomas, those who have the worst prognosis, means only 10 to 30% get cured, or double or triplet lymphoma. If you remember, DLBCL with c-Myc positive, BCL2 positive in immunohistochemistry, in fish, mutation, etc. It's called double hit or triple hit DLBCL, B cell lymphoma. Then there is a very aggressive, there are two aggressive T cell lymphomas, angioimmunoblastic, hepatosplenic, practically incurable diseases. So that's, a very brief, superficial overview of lymphoma, mainly for your orientation. Thank you. I'll be
Thank
happy
you,
to take.
Dr. Sachin. I think it was a very simplified topic. We as GPs face lot of issues with, as you rightly said, about TB, or whether it is lymphoma, or whether it is Kikuchis and things like that. I think this session is very well simplified for us. Over to the audience for more questions.
One input from my side: if you are not sure, if you are delaying a biopsy, don't give steroids. Okay, FNAC, somebody calls it Kikuchi, etc., you are tempted to give steroids. Never. It will kill the cancerous lymphocytes and you will miss a diagnosis. So if you're going to start steroids or something like that, please biopsy first. Okay. Anybody has any questions? Let me look
Sir,
at the chat.
I have a question, sir.
Yeah, go ahead.
Sir, I have a question.
Yeah.
In the beginning, first slide, you said the lymphocytes in the lymphatic system. So, is there any difference between the lymphocytes in the bloodstream and the lymphatic system?
No, they are the same. See, lymphocytes are like your soldiers who are roaming around. Okay, they are soldiers who are roaming around in the blood, trying to ensure that they're going through the blood. It's like soldiers, walking across a border to see if there are any terrorists coming. They are exactly the same. It's just that they start from the marrow, go in the blood, get into lymphatics, sit in the lymph node for some time, then again start floating.
Sir, in pediatrics population, generally we see repeated upper respiratory tract infections, and because of that, they'll have some sort of presence of lymph nodes, that to multiple lymph nodes for little long duration. So in that condition, maybe once in a month or once in 2 months, they'll have some sort of infections, but in between they'll be fine. So at that time, you still recommend to do biopsy of the lymph nodes or
No,
wait and watch.
no. So see, if there are cervical lymph nodes secondary to upper respiratory tract infection, as the infection subsides, the lymph nodes will disappear. But if they persist for more than 1 to 2 months, or they're growing in size when your cough cold fever has gone, but the lymph nodes are growing, then you need to biopsy, not otherwise.
So only if it is growing in size or growing in number, then we have to do biopsy.
Yeah, yeah, and persisting for more than 2 to 3 months.
Sir, I have a question, sir.
Yeah.
Sir, especially young, again, pediatric kids who have got adenoids and tonsillitis, and they develop the cervical lymph nodes. Now, mostly tonsillitis, they operate tonsillitis, but the lymph nodes continue to remain there, and there is repeated problems. Shall we do tubercular screening in those cases or not?
Of course. See, chronic tonsillitis, chronic adenoid hypertrophy is a different problem that happens in children. In that, your ENT surgeon will decide whether to remove the tonsils, remove the adenoid or not. After they are removed, they have to be sent for histopathology. Okay. If you send them for histopathology and it only shows reactive enlargement, then you're not worried. You're not worried about TB, you're not worried about lymphoma,
Hmm.
right?
So, but this is the main issue, especially in the pediatric. Right, sir.
See, also in lymphoma, what will happen is if this child's cervical lymph node or lymphoma, slowly you will start seeing axillary nodes also. Correct. Now that can't be because of adenoid, or inguinal node can't be because of. So if you are seeing multiple sites,
Sir.
right, what I had said in this slide. So if you're seeing multiple sites, right, then you have to err on the side of biopsy.
Now, another Byret's one patient's having axillary lymph nodes bilateral.
Hmm.
Shall we go for biopsy or not?
So if the axillary lymph nodes, okay,
Yeah,
in a lady
sir.
are associated with mastitis,
Hmm.
different issue altogether.
Definitely,
Correct. You will also do a mammogram.
sir.
Mammogram does not show a lesion,
Sir.
but the lymph nodes persist and there are no chronic infections on the draining area, that is the upper limb.
Sir.
The lymph nodes are persisting after 2 months, 3 months.
Sir.
Biopsy. Simple.
No, I missed out. What do you say, sir?
You should. So when you've ruled out CA breast, when you've ruled out mammary infection,
Hmm.
when you've ruled out no other draining sites such as the upper limb having
Hmm.
infection, right? And
Sir.
the lymph nodes are still significant. The other
Sir.
thing I want to tell you I missed, tiny lymph nodes less than 1 centimeter are generally not malignant.
Agreed.
So if your ultrasound or PET CT or CT or MRI shows, sub-centimeter lymph nodes, we don't biopsy. They are generally reactive infectious. But 2, 3, 4 centimeter lymph nodes which are not resolving, no other obvious cause, persisting for more than 2, 3 months, you're going to biopsy.
And what about mesenteric lymphadenopathies? If there is, and but there is nothing, no other. thing, but in an ultrasound it shows mesenteric lymphadenopathy.
So
How to
then
proceed on
you do a CT scan if this or a PET CT. If the PET CT shows that there are multiple nodes, different sides, 2 3 centimeter,
then to
right?
we have
And your FDG
treatment
shows
changes.
correct. If your FDG shows that SUV levels are more than 5 or more than
Hmm.
10, see SUV level less than 5 are low grade, could be low grade lymphoma, but could also
Okay.
be SUV levels more than 5. So that is what you will do to decide whether to biopsy or not.
Bye, sir.
You have ruled out everything, lymph nodes are there. It's better to do a CT guided biopsy at that point.
Got it, sir.
Sir, sir, I have a question. Suppose we
Yes.
have a suspected lymphoma case and we conduct an excision biopsy because many family physicians are trained in doing it. Which are the labs do you think have good hematopathologists where we can coordinate with the hematologist and send the sample?
So, see, generally, if you have a regional cancer center near you, then those pathologists have seen so many histopath tissues, they're quite good, provided they have immunohistochemistry. So, your Kidwai, RCCs, etc., they are good. Tata is wonderful. Then, of course, the goddess of lymphoma pathology or oncopathology is Dr. Anita Borges. She has a wonderful lab in Mumbai. And Dr. Jay Mehta is there. So you'll have to find out pathologists which are keen on hematopathology, lymphoma histology, and who have immunohistochemistry. There are many people, everybody will say, no, no, we will do it. And they will just do an HNE and they are not sure. They'll say, yeah, maybe there's a granuloma. No, send to the right person for the first time, get the right diagnosis.
True, sir, because we always have problems in diagnosing a proper tubercular lymphadenitis case versus others. So that is when, though clinically we may not get much symptoms or signs apart from the lymph node enlargement.
See, today morning I saw a patient, a 60-year-old gentleman from West Bengal, has back pain for almost a year, then had a small scooter accident, neglected the pain increased, went to an orthopedician. The orthopedician did an X-ray. He has clear local pain. You press on the spine, lower thoracic, and it hurts. X-ray said, hey, there is nothing. Then he got paralysis of the left lower limb. Okay. Then he went to another orthopedician, another doctor. They did an MRI. MRI showed lytic lesions in multiple vertebral bodies with soft tissue because the lymphocytes are growing with soft tissue. And this soft tissue and vertebral fracture was compressing on the spinal nerve, okay, leading to monoplegia, paraplegia of the left lower limb. Then what they did is they did a CT guided FNAC. FNAC shows lymphocytes. Pathologist thinks chronic inflammation, writes rule out COX. Okay, 2 weeks gone. So then everybody goes on a tangent. Hey, let's check HIV and this and that. And then they do CT chest. CT chest shows some apical scarring. They say, yeah, yeah, old COX. Now spinal lesion T12, L1 COX. What else can it be? Right? 1 week of anti-tuberculous therapy. After a week, he gets jaundice. There is some hepatotoxicity of the anti-tuberculous therapy. Then what they do is they go to another doctor. This time the doctor does a CT guided core biopsy. And the core biopsy then is suspicious of lymphoma. Then they travel to Bangalore, go to a spine surgeon. The spine surgeon stabilizes the spine, but now it's too late. The paraplegia of the left lower limb is fixed. If you don't operate, if you don't give steroids, and if you don't give radiation within 48 hours, that paralysis will never recover. Any which way, what should have happened is a biopsy should have been taken and steroid should have been started. Now the spine is fixed and now there is good tissue. The tissue, a pathologist says, sheets of small to medium sized cells, probably lymphocytes, suspicious of NHL. non-Hodgkin lymphoma, and he's sent to me for treatment. Then I say, but we need to do immunohistochemistry. Is it B cell, T cell, CD20 positive, high grade, low grade? Because diagnosis changes, prognostication changes. All the story started on 10th of April. It's almost a month. Now he has leg lower left side paraplegia, monoplegia, and because the left leg is not mobile, he has gotten deep vein thrombosis. For deep vein thrombosis, somebody has put an IVC filter. So you see, we've gone on a complete tangent, right? That's the problem if we don't do correct test and send it to the correct people. Yeah. Peripheral smear LDH. Yes, LDH is high in most of the high grade lymphomas, but not all. And because the tumor size, number of cancer cells in lymphoma are very small, whereas in leukemia there are so many cancer cells across the bone marrow and the blood that LDH is high. But lymphoma, not all lymphomas will have high LDH. Peripheral smear will show atypical cells only if there is lymphoma spillage and it becomes stage 4 lymphoma in leukemic stage.
So the lymphoma is better treated by a medical oncologist or hematologist, sir.
Doesn't matter. See, we
But
are
generally,
looking.
we doesn't have a hematologist in all the
Yeah,
hospitals,
yeah, yeah,
whereas a medical oncologist is there.
yeah. See, I I have no right to say that I treat a patient better than another doctor. The Medical Council of India has given us the license to treat, right? As long as we are getting immunohistochemistry done properly from the right pathologist, as long as the proper diagnosis and risk stratification is done, and as long as we use the right regimen, do interim PET CT and say, hey, not working, go to salvage, go to transplant. Now, most of the medical oncologists don't do bone marrow transplant. So quite often, and they don't have facilities. So they end up giving multiple cycles of chemo, which are not going to cure. So as long as we are doing the right thing, assessing properly, sending, referring for transplant, those few patients which need, majority don't need. Anybody can treat, whether medical oncologist treats or hematologist treats or radiation oncology treats. If you are doing the right thing, no problem. We are, after all doctors and we are all friends. So we actually have a system. I founded International Hematology Consortium 5 years ago, and I have now about 320 odd medical oncologists and hematologists. We have weekly, academics there, and anybody has any patient, we ask each other questions, and if somebody wants to give treatment, my team, we I give them the protocol. Here, take the protocol, you treat. Doesn't matter whether you treat or I treat or anyone, as long as we are using the right medicines, right dose, etc.
So regarding this IHC markers, is this markers are compulsory for all the malignancy biopsies or any particular thing?
Well, today pathology is based on IHC. IHC has become baseline. Beyond that, we have genomics. You know, it's like asking, do I have to do TROP-T to diagnose AMI? My ECG is showing hyperacute AMI. Do I need to do troponin? Yeah, because we have gone beyond that. In fact, we will do primary angioplasty now. Correct? So, science has moved way beyond just HNE based, hematoxylin eosin stain based basic pathology. It's gone far, far ahead. You'll be surprised how many times Ewing sarcoma gets reported as lymphoma and vice versa. You'll be surprised how breast cancer is missed because cells look the same. I mean, you look at this, if you look at these images, it's not easy to make out which cell this is. They all look so similar. You need to stain them to see the color, right? Which, if it is picking up a particular, it's like flow cytometry, what I told you. If it is picking up particular color against an antigen, then that antigen is present, and that antigen is only present on this cell. Hence, it must be this. I can't make out what is this until nobody can. It's humanly impossible. It would be interesting for you to note, when Professor Hodgkin, I will get his first paper, when he first presented the seven patients which he said, he noticed the Reed Sternberg cell and lymphoma. That's how the name Hodgkin lymphoma came on. Later on, when those patients were tested with, modern immunohistochemistry, some of them were not Hodgkin's. They were non-Hodgkin lymphoma, right? It's like you do an X-ray versus a CT. Of course, CT will give you more information, right? And more
Now, why I
reliable.
asked this question? Why I asked this question was recently one of the patient had endometrial CA, and the biopsy confirmed it's endometrial CA. So, for immediately, this patient has been taken to a reputed hospital, corporate hospital in Bangalore, and they said we'll start chemo and further treatment. So I luckily that patient son, he was very close friend of mine. So he showed me all the reports and then he asked what to do. I said IHC markers is not done and PET CT is not done. So let us do all these things and then go for the treatment. So at that time they gave connection, teleconsultation with the medical oncologist. So I asked the same thing with the doctor, saying that let us come to a final diagnosis and then we'll start the treatment. They said, "Why are telling all these things to us? We know what to do." That is the final answer I got it. That's why I asked you,
So,
sir.
yeah. So I am not trained in solid tumor oncology. I'm not trained in endometrial cancer. I can't tell you whether all endometrial CA need IHC or the diagnosis is made on HNE. Okay. Broadly, conceptually, I can tell you that, hey, look, IHC is done for most of the biopsies today, not just oncology, even other biopsies. With we diagnose CMV and histoplasma with IHC and special stains. That's my conceptual understanding. Now, whether your friends, a relative should have had IHC for endometrial CA, I don't know. I'm not trained in that.
After 2 months, they got it, sir.
What IHC?
Yes.
Okay. I don't comment on what other oncologists do, it would be unprofessional of me to judge somebody without knowing the patient. So we do our work properly and we leave it at that.
Thank you, sir.
Just feel free to call whenever you have such patients. Generally, being in this field, we are aware of who's a good, reliable doctor who does scientific, ethical practice, and can help you with all of these. Just call. I don't get time to read WhatsApp. Feel free to call, discuss, even solid tumor patients if you like. All right. I think that's it for today. Thank you so much.